I'm Danielle Andrade. I'm a professor of neurology at University of Toronto. I am the medical director of the epilepsy program at Toronto Western Hospital. I am the director of the adult genetic epilepsy program here as well. I'm also currently the president of the Canadian League Against Epilepsy, and I am the chair of the adult DEE task force of the International League Against Epilepsy, and the co-chair of the transition task force, transition from pediatric to adult care in patients with epilepsy, task force of the International League Against Epilepsy. I started with the brain. I was very interested in becoming a neurologist since first year medical school. When I studied neuroanatomy, I was fascinated by that. And I also was very interested in genetics. And this is like since high school. So I eventually combined neurology and genetics. And during master's, I wanted to study genetics of the brain, and I end up studying genetics of a form of progressive myoclonus epilepsy, which is a very severe form of epilepsy for which we don't have a treatment until this day. And then after that, I said, that's it. I really like to study epilepsy. I think there's too many things to learn and to do and possibly help patients, and that's it. We talk about epilepsy. It's not just a brain making seizures, it's the whole person. A person with epilepsy has not only seizures, but a lot of other things. So sometimes there's associated depression, anxiety, sometimes autism, sometimes there's a bunch of different things. And we are learning more and more that there's also sometimes heart complications, sometimes memory issues, and a bunch of other things. So, of course, one of the most severe things is death in epilepsy. Unfortunately, epilepsy can kill more than certain forms of cancer. So the number of people with epilepsy that dies could be higher than in certain forms of cancer when you catch it in the early phases. So death in epilepsy is something extremely important that is being more and more studied, but still there's a lot to learn. So this project in particular, we are looking at possible causes of SUDEP, sudden unexpected death in epilepsy. We decided to look at this in one subgroup of patients with epilepsy, those patients that have Dravet syndrome. And why? Because Dravet syndrome, first of all, has a very high mortality rate, unfortunately, but they are somewhat homogeneous group in that Dravet syndrome is caused by the same genetic abnormality in a large majority of people. We can isolate at least one of the confounding factors of epilepsy and death in epilepsy. And what we are doing is we are looking at patients with Dravet syndrome, this form of epilepsy, and doing prolonged Holter, so prolonged monitoring of their heart. And we work in collaboration with amazing scientists that are actually looking at the tracing of the heart to try and understand if there is something there that predisposes them to cardiac arrhythmias that could lead to death. In addition to that, we are going to be looking at the genetics of this patient. So even though I said they are somewhat homogeneous because they have the same genetic abnormality, they do have one gene that has, when it is mutated, it has a very large effect, so it causes that disease. But what we want to do is look at the background genes, the background genome actually, and see if in the rest of those thousands of genes, is there a predisposition to cardiac arrhythmia that could be part of that lower threshold for severe cardiac arrhythmia. Funny enough, is logistics. Logistics. So, because this is a somewhat rare, well, it is a rare disease. We don't have all patients here in Toronto. We have patients spread across several cities in Canada and abroad. So getting the Holter to those patients and getting it back is actually a big challenge. But we are managing that. We are managing that. It's just the project. It's taking longer and than we had initially planned. So we hope to be able to identify who is at higher risk of severe arrhythmias, that we could do some intervention, either medication or pacemaker or something that can be used to avoid a more severe arrhythmia. Well, without Epilepsy Canada, we wouldn't be able to do this. So Epilepsy Canada is actually funding the whole project. And yeah, we wouldn't be able to be doing this without them. So we're very grateful, and we hope we will deliver the results that we said we would, and continue to do research. Epilepsy is a disease that, for the most part, has good treatment. If someone with epilepsy is still having seizures, they should they should go to a center where they specialize in epilepsy. So epilepsy is relatively common. 1% of the population have epilepsy. So you have many people that treat epilepsy, many physicians, and this is great. But if it comes to a point where you hit a roadblock and the treatment's not working, it might be worth to be seen in a center that specializes in epilepsy, where they might have treatments that are not available in other places. There's a lot of that. So I've been very interested in several things, but one of them is how patients with epilepsy age. What happens in terms of their brain, their memory, their cognition, their ability to carry on their lives, their motor system, their gait, how they can continue to perform activities of daily living. Also, what is the influence of not only seizures and anti-seizure medications, but their genetic background, how they age. So we have done some research showing that, particularly in this disease, Dravet syndrome, patients seem to age much faster than the normal population, or even other patients with epilepsy. The patients with Dravet seem to have problems of old people when they are in their 30s or 40s. So why is that? What can be done to prevent or slow the progression of those things? So that is an area of research that I'm very interested. The other thing is different form of epilepsy, which is actually common, one of the most common ones. But again, it's called juvenile myoclonic epilepsy. It is basically a genetic epilepsy, different from Dravet, where you have one gene with a strong effect. This is a combination of several thousands of areas in the genome that lower your seizure threshold. But we see that patients with JME, juvenile myoclonic epilepsy, some of them, and the majority of them, respond very well to anti-seizure medication, and seizures are controlled, but they can still have other problems like impulsivity and, again, depression. And some of those patients don't respond so well to medication. A small proportion of them don't. So we are investigating why. They should be completely controlled with a small amount of medication, like most patients with JME, but they don't. So is it in their genes? Is it in their mitochondria? So we are studying that as well. I like music. I don't play much anymore, but I like different types of music. I like going to concerts. I like gardening, and I like ballet. Again, I don't dance anymore, but I love going to the ballet.